Hello, everybody. I am making the tape for pain assessment, the fifth vital sign. This will be chapter 10. These are the two chapters I missed, chapter 10 and chapter 11. Chapter 10 being pain assessment, and chapter 11 being the nutritional assessment. So, um, pain assessment, the fifth vital sign. Um, we can start with pain. I would discuss pain by basically saying that everybody knows that pain is a subjective thing, and I want to make sure that everybody knows that pain is subjective. I also want everybody to know that pain can be very debilitating. Pain is something that I do not want anybody to ever judge when it comes to a patient, because it's an individual thing. It's very individual. So, uh, pain. Pain is what they consider highly complex, and it's a subjective experience. And pain originates from the central nervous system and or the peripheral nervous system, or both. Most of you guys remember what the central nervous system is, and that is responsible for various sensations, and the central nervous system is composed of the brain and the spinal cord, and then the peripheral nervous system, which is nerve endings. Okay, so um, I want you guys to be able to tell me the difference between the various types of pain, and I want you to be able to, if it is said to you about what pain is, I want you to be able to highly describe these different types of pain. So, pain, you have nociceptive pain. I'm going to say that again, nociceptive with two C's. Pain. Pain receptors are stimulated from injury. Uh, these pain receptors are um, they develop when functioning and intact nerve fibers. So, in the periphery and the central nervous system are stimulated. It's triggered by events outside of the nervous system, from actual or potential tissue damage. So, when your body has some type of trauma, chemicals are released at that particular site. And so if you think a noxious substance, you can relate to what a nociceptive pain is. It's stimulated from an injury or a trauma. Okay. The difference between neuropathic pain, which is another type of pain, or classification, I can say, of pain. Neuropathic pain is an abnormal processing of the pain message, and it extends after the injury has healed. Now, listen to me. Neuropathic pain is pain that does not adhere to the typical and regular predictable phases in nociceptive pain. And I'm going to go over, so this type of pain extends even after the injury has uh um even after the injury has occurred. And that's the reason why I say things like um neuropathic neuropathies. Okay, so you have neuropathies. When people say they have neuropathy, and because there's an abnormal processing of the pain message, and it's usually a lot of times in the periphery, a lot of times it is in the periphery. That's because the nerve cells are altered. So you could think about people who have neuropathic pain, like people who have diabetes, people who have herpes, HIV, sciatica, those type of things. Um, they have even phantom limb pain, where people have phantom limb, like they get if a person gets an amputation and they feel like that left leg that they might have got amputated is still hurting. That is, and it's real to them. So it's a abnormal processing of that message, and it extends after the injury has healed. So the difference between nociceptive is you have receptors that are stimulated by injury. Nociceptive, you have receptors that are stimulated by you having some type of injury. And neuropathic is an abnormal processing of the pain message. Okay? So we talked about nociceptive being um, stimulated by um, you having some type of injury or stimulus. Well, nociceptive pain is divided into four phases. The four phases of nociception pain uh, can be transduction, transmission, perception, and modulation. So I'm going to give you an example of starting with transduction. For instance, transduction occurs when a noxious stimulus in the form of a traumatic or chemical injury, for example, if a person has a burn, an incision, or a tumor that takes place in the periphery, um, which can include skin and visceral structures, which could include organs. Um, they release certain substances like histamines and prostaglandins, and these chemicals are neurotransmitters, and those neurotransmitters are what sends the pain message along the nerve fibers to the spinal cord, and that's where individuals tend to feel that pain. Okay, so that's what happens when you have transduction. Uh, People get that injury, you secrete that those noxious substances, and then it goes towards the spinal cord, which is one of the forms of which is one of the forms of you developing pain, and you take it from there. And it carries the pain impulse to the spinal cord. In the second phase of nociception, which is, and this is at the cellular level, you guys, nociception, which is transmission, is that once it gets to the spinal cord, the impulse moves from the spinal cord to the brain. Once it gets to the spinal cord, it moves there to the brain. And through that, it goes towards the thalamus, and that's where the actual pain, uh, I guess you could say that pain message is sent. So first you got the transduction, where you get the injury, it goes to the spinal cord. Once it leaves the spinal cord, it's going to be transmitted. So it's transmitted from the spinal cord to the brain. Okay. Then the third phase is the perception. And the perception is when you actually perceive this as a painful experience. And that's because of the fact that when all of this happens, or when it's going through that transmission phase, and into the thalamus, is telling your brain and everything to release that cortical, that cortical. And that's what helps you say, oh, wow, this sucker hurt, you know? And that's where the perception is, where you actually identify that this is pain. Then you have modulation. And that's the last pain message, modulation. And that's when our bodies will eventually like slow down and stop processing of a pain stimulator. And that happens by all these endorphins and stuff in your body, or neurotransmitters, and things like serotonin and norepinephrine and those type of things, which are what they consider indigenous things that are in your body, that are almost called indigenous opioids. And opioids uh basically, um how can I say, opioids basically relieve pain. So you got the transduction, transmission, perception, and modulation. I'm going to say once again that you need to know what these each are. Transduction, you need to think about the actual injury, release of histamine, uh, and then transmission is when the signal goes to the spinal cord, right? It goes to the spinal cord, to the brain. Then you release higher corticosteroids, and the corticosteroids, and that is that final part, that perception part, which makes you say, when you in that perception phase, you're like, ah, that's that pain. So all of this happens within a second. This is what's going on when you touch that hot iron, or you touch something that hurts you, all of these phases. And then the modulation is the phase where basically uh you start releasing endorphins and indigenous opioids in your brain, which block the pain impulse. So you need to know this uh sense of pain. You need to know that, which is nociception, the four phases. You also need to remember once again that this is uh, type of pain, and this is the and it's the pain uh, that's from an intact nerve. Okay, so next, the sources of pain is based upon where they originate. It's based on their origin. Okay, sources of pain is based on where it originates or uh, its origin. Uh, you have what they call visceral pain. Now, what does that sound like when you say visceral pain? Uh, Visceral. Oh my God. I don't know what that could possibly be. Visceral pain originates or starts. You can use the word start or origin, originate. It's in big organs like the stomach, the intestines, the gallbladder, and even the pancreas. This type of pain is often described as a dull, deep squeezing or cramping type pain. People who have this type of pain may have this pain from an inflamed gallbladder, appendicitis, a tumor, uh, distension, which means your stomach is swollen or big for whatever reason. This is a type of pain that's from a big organ. Okay. Then you have what they call deep somatic pain. Now, visceral is the big organ. Deep somatic pain. Deep somatic pain is musculoskeletal. Musculoskeletal pain or the body surface. So deep somatic pain comes from sources such as joints, tendons, muscles, bone. When you break a bone or lack of blood to an area. So when you break a bone or you have problems with your blood flow, like you got lack of that, that is also considered um, somatic pain. Then you have what they call cutaneous pain, and that comes from the subcutaneous tissues, which is the fatty tissue that's right below that epidermis. And that's what I was telling you. You don't really have pain per se in your epidermis, that little that little layer that lays on the very top of your skin for protection. So it's usually cutaneous pain uh, is usually in the skin surface and subcutaneous tissues. And it's superficial and it usually feels sharp. Like for instance, that cutaneous pain, that's a sense of it's a nociceptive pain could be when you burn that epidermal layer off and you hit it real quick. That is considered cutaneous pain. Now, the last type of pain is called referred pain. And you'll hear people talk about referred pain. You'll hear people talk about what is a referred pain. Well, referred pain is basically it originates or its origin is from one spot, but you feel it in another spot. And I'll give you an example. Referred. I remember I had kidney stones, and I was riding down the street in my car, had kidney stones, and all of a sudden, you guys, my chest just started to hurt so bad. My chest was just like killing me to the point where it took my breath away. And I'm thinking the nurse part in me kicked in, and I'm saying to myself, like, well, my God, um, what's going on here? I got this pain. It's really hurting me. Uh, I'm short of breath, and I start going through the motions like, okay, is it running down my left arm? Because I'm thinking at this point, like, am I having a heart attack or something? You know, and I actually literally had to just pull over and sit there for about 30 minutes and just get my bearings before I went home. And it eventually went away. And then the pain came back. And I'm like, at this point, you guys, I'm just like, okay, now, what the heck is this? The pain comes back. Well, I can say to you, the pain was so bad and it was in the middle of my chest that I ended up in the emergency room. So they did an EKG, they doing all this. It's not her blood pressure. She didn't have a stroke. She didn't have a heart attack. She's not. All my cardiac labs was okay, everything. So then they decided they're going to do a CT scan, a CAT scan. And when they do a CAT scan of you, they generally will do abdominal, they'll do the chest and the abdomen down to the pelvic area. Okay? So they did the CAT scan, they came back, and guess what? I had kidney stones. I was trying to pass. And I don't know if anybody knows about kidney stones, but they can be very, very painful. So I had kidney stones, and you would wonder to yourself, well, she had kidney stones. Why was her chest hurting? Why wasn't her flank area or her back, lower back flank area hurting? Well, my chest was hurting, and that was an example of what one person would call referred pain. So, and a lot of times they say it might happen because of the fact of just maybe you cutting off, you getting ischemia, which is lack of blood or whatever flow, through a certain area, and and it blocks something or whatever, and that's why it comes out that way. So what I'm trying to explain to you is of all these types of pain, uh I want you to know what the sources of these pain. If I was to give you an example and I was like the person having pain and it seems like it's in their liver, you know that that would be considered visceral pain. If I was to tell you that a person was having pain uh and they had broke their patella, that would be deep somatic pain and et cetera, et cetera. So that is how I want you guys to understand this. So nociceptive stimulation of cutaneous and deep pain nerves with noxious substance or inflammation, described as somatic, dull, aching, localized, nocturnal at night sometimes. Visceral is deep squeeze and pressure and poorly localized. disorders, all types of disorders, post-op pain, bone mets, which is bone cancer, arthritis, sports injury, a mechanical or back injury, cancer, liver mets. All of these types of things are things that you would see when you talk about a nociceptive pain. So you would treat that underlying cause, whatever the cause, and treating the underlying cause may mean that you might have to get something removed or might have to have a surgery. You can always use NSAIDs, which is something like a Motrin or something. Opioids, which can be used for pain, muscle relaxants, steroids, and biphosphate. So those are the type of things that you use for the treatment of the various types of pain. Neuropathic pain. Remember I told you guys that when you have a neuropathic pain, it's almost like it's a disruption. It's not a normal finding. It's not a normal type of functioning of your central nervous system. And that can be caused by you having a lesion. And when I say a lesion or neuroma, it could be some type of tumor. It does not necessarily mean that that tumor is malignant or cancerous, but it could be sitting on a nerve and interrupting the signal. And this can be described as constant, dull, achy, burning, uh, vice like electric shock, numbness, tingling, all of those type of things. So the type of disorders, remember I said neuropathic, diabetic neuropathy, post-stroke, herpes, trigeminal neuralgia. That's the pain that people get in their jaw when people be saying that they have TMJ. Back pain, complex regional pain syndrome. Okay, you can use all types of therapy. You can treat it with surgery, anticonvulsant. Um, you can use antidepressants of sorts to treat that pain. You can use a local anesthetic, a corticosteroid, a opioid. All of those things can be used when you trying to impact or you trying to treat that type of pain. Um and biphosphonate the same thing. So I do, would like for you guys to just um remember that. And remember that pain, you guys, is very complex. And so how you treat pain and what you do for pain is could be different, for everybody. So I just want you all to know that don't think that every treatment for everybody and everything is the same. Okay. Then there's one more type of pain that we didn't mention, and that's cancer. And that's when you have infiltration of the lesion. You have nerve injury from the periphery or central nervous system. So it could be either one. And it depends on whatever the underlying pathology is. So it just kind of depends on where you have that cancer at. It could be in the periphery or the central nervous system. So it could be considered uh, 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 neuropathic or nociceptive almost, but it's just, and it disorders bone metastasis and neuropathy. And basically, what you do with that type of pain is you just control the symptoms, because a lot of times there's not too much more that you can do, about that. So you do have the types of pain, and I know I've described this to you before. You have acute pain and you have chronic pain. And I want to make sure that you guys are real sure on the difference between acute and chronic. Acute is short term, it's self limiting, it's usually due to an injury, and it dissipates when the injury heals. So it stops when the injury heals. Usually it's less than 6 months. Chronic pain lasts for 6 months or longer. And that pain, even after healing has somewhat occurred, it can still go on. It can fluctuate too. 1 minute you hurting from it, 1 minute you not. And it can be malignant or non-malignant, which is saying basically it can be cancerous or non-cancerous. One of the biggest and one of the uh, types of pain that most people complain about for chronic pain is usually some type of musculoskeletal condition, like a lower back pain, you know, or arthritis, which could really turn a pain into something chronic. And then fibromyalgia. Now, you won't hear me talk about fibromyalgia yet. Is because although I know that there are people who have been diagnosed with fibromyalgia and that's real to them, I'm not judging. I just have a problem with fibromyalgia because when you look up fibromyalgia, it just always says that they don't know really truly what it is, what the origin really is. I mean, if you don't believe me, look it up. So I noticed that it seemed like whenever somebody was in a lot of pain, because when I did the little contract work for the military, it seemed like whenever somebody was in a lot of pain and they couldn't figure out what the source was, they would always stick fibromyalgia on them. And that's the only reason why I kind of feel the way I feel. Because if you look it up, it'll say unknown etiology. Everything is real vague and unspecific. I just really want to know what it is. Remember, I told you guys it's hard for me to learn stuff if I don't have any explanation. But people say it's something. I guess the physicians and the experts say it's something, so we can go with it. Okay, as something that's considered chronic pain. So know the differences and know what type of injuries people would have with these type of pains. Cultural considerations. There's always cultural considerations. Um, Gender differences are influenced by societal expectation, hormones, and genetic makeup. So, um, I could say to you that traditionally men have been raised to be more stoic about pain and more like affective, which means affective, which means you don't see as much response. Or, and I think that would be because people tend to accept because of the fact that women tend to have more hormonal changes. People tend to accept females having more expression of pain. But I don't necessarily think that just because the men are more stoic, I think that they tend to show, and this is just from things that I have seen, they tend to show not as much of I could say they tend not to show as much of a tolerance to pain, even though they tend to be a little bit more stoic. And a woman will tend to say, God, oh, this hurt. But it seemed like the tolerance level, because just think about this. Anybody that can push a baby out, I mean, you got something there. You know, uh, I think overall we tend to tolerate it just a little bit more, just a little bit more. Okay. So, um, then, as far as cultural expressions, um, cultural expressions, most cultural differences relate to expression and management. For instance, when we talk about you got kids, um, when you have little infants or kids and stuff, the only way they can show you that they in pain a lot of times is to cry. And they tend to have more of like an emotional pain. So therefore, there's a big awareness out there that sometimes before they're what they consider verbal, that a lot of times that there may be under treatment of pain. And the under treatment is because of the fact that a lot of times people say stuff like infants don't remember pain. And they say that that's, a myth. And even when you think about like a older adults and people like that, they're um uh old and they may perceive pain at a lesser degree, and that may be because of the fact that their sensitivity is diminished. um so we can't just assume. You have to look at although with older people I do feel that less is more, but they may tend to underreport pain. So, or they may not want to take pain medication because of maybe thinking something is a financial burden. Or you have people sometimes that tend to not want to take something for pain because they think that they're going to be addicted to a particular pain medicine or something. But that is not true, because if you're truly in pain, and you just treating just that pain, uh, chances are that you won't get addicted. There are a lot of different ways. And then like when you talk about expressions of pain, like we talked about the gender differences, that goes along with cultures. Different people from different types of cultures may be more stoic when it comes to pain, and then you may have individuals who might scream out loud because of the type of pain they are. So you're gonna have to make sure that when you are assessing somebody and you assessing that individual for pain, that you take into consideration everything about that person when it comes into as far as pain. Okay, so you're gonna do your subjective data, and that's gonna be what the patient says, and it's the initial pain assessment. You're gonna ask them, where is your pain? Where did your pain start? What does your pain feel like? How does pain do? How much pain do you have now? And when you do that, like for instance, what does your pain feel like? You looking for words like burning, stabbing, aching, squeezing, itching, tingling, dull, cramping, sharp, all of those type of words. That's what you're looking for. And based on the type of things they say, you can tell whether or not it's a neuropathic pain, which neuropathic tends to be shooting and tingling, or a nociceptive pain. Because a nociceptive pain, remember we said a lot of times it's more visceral, it'll be more aching, uh, throbbing, so those are some things that you need to keep in the forefront of your mind. What makes your pain better or worse, including behavioral things, uh, pharmacologic, when you take this non-pharmacologic interventions. There are a lot of different things that a person can do that uh might make it better or might make it worse. They might say, well, when I lay down, it really hurt, but when I sit up, it is a little bit better. So you want to know those things. How does your pain limit your function or activity? Remember when I was telling y'all that a lot of times when people have pain, if they have pain and they stop doing something that they really, really enjoy, that's the reason for you asking about limiting your function or your activities. How do you usually behave when you are in pain? How would others know you are in pain? You want to ask um, those type of questions because nonverbal behaviors are extremely verbal, especially when a person have chronic pain syndrome because of the fact that sometimes people are in so much pain and they've been in so much pain chronically for so long that they don't even know what it feel like, to not be in pain. So they kind of almost conditioned themselves to almost tolerate a pain when it's chronic pain. So that's something. And I've had people tell me that may no longer be in pain and they'll start because they got treated and they got treated the right way. And they may be like, man, I didn't know I was feeling this bad until I was no longer in pain, you know? How do you usually behave? Okay, what does the pain mean to you? Why do you think you are having pain? When I say what does it mean to you, you want to know what does it mean to that person. You want to know what is it that is do they think that it's a curse or do they think it's because they just getting old? Or do they think they got cancer? Do they? You want to know what that patient's perception of their pain is. So, when a person has acute pain, you guys, these are the type of things that go on with them. Acute pain is that initial pain that it usually hurts more, but it goes away. Okay, remember I said no longer than 6 months. They have tachycardia. Tachycardia means that their heart rate or their pulse rate goes up above that when we gave that range of 60 to 90, above that. They have increased blood pressure. That's why it's important to take vital signs. Hypoventilation. So they're hypoxia, can't hardly breathe. They got nausea and vomiting. Have you ever been in pain so much that you will throw up and they feel fearful and anxious? Those are the signs and symptoms I would suggest that you would remember. Chronic pain, depression, isolation, limited mobility and function, confusion, family distress, diminishing quality of life, and lack of sleep. All of these things are because of the fact that this type of pain has been going on forever. You see? So it has changed the whole total quality of that person's life. Okay. Remember, I was telling you guys about existence of patient behaviors, existence of pain and severity is based on the patient's report. Pain is what the patient say the pain is. In the case of stoic or nonverbal patient, cues, we talked about cues, and you make inferences based on person's cues, right? Can help determine the existence of pain. So all of those type of things, change in vital signs, if they agitated, if they scared to move, or if they restless, if they sweating, if they guarding. Guarding means that, like for instance, let's say they stomach hurt, and as soon as you get near their stomach, they move their arms in front of it so that you can't touch it. Groaning, grimacing, all of those things are behaviors that you need to be watching for in order to assess a person's pain. Okay? So, I want you guys to be aware of different types of things, different types of pain, different types of pain behavior. And I also want you guys to also be aware of um um there are different various types of pain scales. And if you look in your book, it'll show you different types of over pain assessment school tools. They have what they call just standardized assessment tools where it assesses every single thing, that even have a pictures of a person's body where you can mark on it and show where that person is in pain. And uh then it has like scales, 0 to 10. uh like 10 is always, you guys, the worst. Okay, and that can help you assess a person's pain. They have it usually has a numeric rating. Then so the numeric pain area is for pain intensity, how bad it is. So that's why when we ask a person, we'll say 0 to 10, 10 being the worst type of pain. And then people who can understand, they can give you an idea of what it is. Okay? Now, the FACES pain scale is generally for children. Okay? Children 2 years of age can report pain and point to the location, but it's a lot better for them. And they have one they call the Oucher scale, the Faces pain scale, different things like that. And those are tools where a patient can look at the face and let you know by just how intense the face look. Usually there's about some of them have smiley faces. Usually basically what the deal is that they'll look at that, and they'll point to what is the best type of pain. And they have one called the flat scale, and the flat scale, FLACC. And they have one that's called the CRIS, CRIS. ES. And it's from 0 to 2. 0 to 2. And CRY stand for crying, requires oxygen. And this is for a baby that's like a neonate. Increased vital signs, expression, and sleeplessness. And sleepless. So like 0 being, oh, they not crying, 2 mean that they just unconsolable. And you do that for each category. You also have uh what they call the flat scale, and you basically you add up everything on the flat scale, and they use that for young children that are under 3 years old but they have some type of uh problem. And they well how they summarize it. And don't get scared about these different scales that they have, because how they summarize it is it'll be on the actual scale. So like when you finish uh like face, legs, activity, cry, and consolability, that stands for the flat. In each category, each of those 5 categories are 0 to 2. And y'all know that 2 is going to always be the worst. What they say is you can tell, and they that a person is in, for instance, severe, if they stuff add up to over 7. Moderate if it's 4 to 6. Mild if it's 1 to 3. So that's how they use like the flat scale. And so they even have a pain assessment in advanced dementia for a patient. And it talks about breathing, negative vocalization, facial expression, body language, and consolability. So uh these are the categories. So you can kind of look at those, and then you can use my uh the blueprint that I gave you to make sure that you're aware of these things. So with that being said, the most important thing about pain, I will always tell anybody, is to make sure that you don't judge. Make sure you don't judge, and never withhold pain medicine. Uh, and a patient pain level is what they say their pain level is. Okay, so that'll be it.